of Chris and myself to our third annual Health Policy Summit. It's going to be a great day. We've got 3 wonderful keynote speakers. We're going to spend the morning looking at health disparities. We're going to be spending the afternoon looking at the future of Medicaid in Missouri. And we have 2 great panels of Missouri experts on these 2 important and timely topics. So we'd like to welcome you all, and particularly would like to welcome the large majority of you who have been to our summits in the past and have come back. So welcome to you.
There's just a few announcements this morning that we want to take care of, but I'd also like to welcome everyone, and also on behalf of Gwen Rodeman and Stan Hudson, who are staff members of the Center for Health Policy, and all of our colleagues at the University of Missouri and other places who are with us today and cheering on our summit. We have several corporate sponsors that we would like to recognize this morning, including the MU School of Medicine, the MU Sinclair School of Nursing, University of Missouri Healthcare, our MU School of Health Professions, the Harry S. Truman School of Public Affairs, Missouri Hospital Association, and Missouri Primary Care Association. So thank you to all of our corporate sponsors for helping put on this fabulous conference today. We also have Primaris Healthcare Business Solutions sponsoring our breakfast, so you can thank them for the terrific buffet this morning. And our afternoon break sponsor will be the University of Missouri School of Social Work. Also, finally, Julie Robner's appearance at lunch is in part sponsored by the MU School of Journalism.
As a courtesy to the speakers, I would ask you to please turn off or put your cell phones and pagers on vibrate. Okay. Also, as a reminder, the program is approved for 6 Category 1 CME credits and 6.9 contact hours for nursing. To get these credits, you have to complete and sign the blue form inside your packet at the end of the program and turn it in, along with your completed evaluation. Handouts and a video of today's program can be viewed at our website, the Center for Health Policy's website, www.healthpolicy.missouri.edu. So after it's over, if you'd like to review some of the talks or share them, you can find them on our website. And you'll be able to download it all after November the 8th. We'll give them a little time to get it on there. Lunch and the networking reception will be next door where you had your breakfast. And be sure that you have a badge on to get into lunch. You'll have to have that and/or your ticket. Restrooms are right out this door and to the left. And the date for our 4th annual Health Policy Summit will be Friday, October the 27th, right here at this hotel. So put that on your calendars now because it's going to be a great one as well.
Let's not delay any further. We have one of the most outstanding speakers with us this morning, and so it's my sincere pleasure to introduce this morning's keynote speaker, Dr. David Satcher. Dr. Satcher is the director of the National Center for Primary Care and the interim president of Morehouse School of Medicine in Atlanta, Georgia. Of course, he is best known to all of us for his service as the 16th Surgeon General of the United States from 1998 to 2002. During his time, he also Secretary for Health, only the 2nd person in history to both of those positions simultaneously. During his tenure as Surgeon General, he continued to battle against smoking and was the nation's spokesperson on major health issues, including youth violence, obesity, oral health, sexual health, suicide prevention, and mental health, among many others. He's a long-standing leader to promote equal access of health care among all of the U.S. citizens, and as Surgeon General, he made health disparities elimination a priority for the U.S. health care system. Dr. Satcher's tremendous career is quite storied, and you can find more information about it in your packet. But he's held various appointments and directorships at Morehouse School of Medicine. He was also at the University of California, Los Angeles School of Medicine and Public Health. He was the president of Meharry Medical College in Nashville for many years and the director of disease registry at the Centers for Disease Control and Prevention. Dr. Satcher has received many awards throughout his career, including the Jimmy and Rosalind Carter Award for Humanitarian Contributions to Health of Humankind from the National Foundation of Infectious Diseases. Of course, he's best known as the Surgeon General who helps make public health work for all people. Now, the title of Dr. Satcher's talk is Eliminating Health Disparities, What Will It Take? So please join me in welcoming Dr. David Satcher.
Well, thank you very much for that kind introduction and warm reception. I'm delighted to be here. I've had other occasions to visit Missouri, and actually this part of the country. I gave the commencement address when I was Surgeon General at the University of Missouri, Columbia. So I have great memories of my visit here. And then, of course, last night I had the delightful experience of being met at the airport by an old friend and colleague, Jack Caldwell. So we had 2 hours to talk and to catch up. So it was just great. It's great to be here. Dean Chris, and to all of the officers of the Health Policy Institute here, I'm delighted to be able to join you. I bring you greetings from the Morehouse School of Medicine, where, as many of you know, I had an opportunity to serve in the early days of the institution. Morehouse is only 30 years old. It was founded in 1975, and I first went there in 1978 to develop the Department of Community Health and Family Medicine, and but stayed only 3 years then before leaving to go to Meharry as president. So it was great after spending 12 years at Meharry as president and then 5 years as director of the CDC, 4 years as Surgeon General, to be able to go back to Atlanta and back to the Morehouse School of Medicine. So I bring you greetings. The building you're looking at there is actually the newest building on the campus. Was constructed to house the offices of the National Center for Primary Care. So this is my office building as well. Morehouse, throughout its history, short history, has been known for its commitment to primary care, to diversity in the health professions, to preparing health professionals for underserved communities. So it's an institution that resonates with what I see as sort of my mission in life. I had a tremendous opportunity to serve as Surgeon General, and I say that because I think Surgeon General in this country is in a unique position to communicate directly with the American people based on the best available public health science, not politics, not religion, but the best available public health science. Now, I don't mean to imply that that's easy in Washington, but that's the history of the Office of the Surgeon General, and sometimes it's more difficult than others to stick to the public health science in Washington, but the American people have come to expect that from the Surgeon General. And in addition to opportunities to speak directly with people throughout the country, I had the opportunity to release 14 reports during the 4 years that I served as Surgeon General. And those reports ranged, as you've heard, from tobacco and health. I think one of the major areas that we had an opportunity to embark upon, there had never been a report from the Office of the Surgeon General on mental health. And of course, as most of you know, the CDC does not have a program in mental health. There is no Center for Mental Health at the CDC. So I'd been concerned about that. So when I got to Washington and became Surgeon General, I had the tremendous opportunity to release a major report on mental health in December of 1999. And it was actually the response to that report that from the American people that led me to really realize how important this was. And so we ended up releasing 3 more reports on mental health before I left, including the landmark report, Mental Health, Culture, Race, and Ethnicity. Also, the Surgeon General's appointment is in a way, even though the President nominates the Surgeon General, the Senate actually confirms the Surgeon General and gives the Surgeon General his or her term. And so I had a 4-year term, and at the time President Clinton had only 3 years left on his term. So when the election took place and President Bush was elected, I had a year left on my term. So I went to President Bush and I said, you know, I understand that you want to appoint your own Surgeon General, so I'd be happy to step down. And he said, oh no, David, I want you to finish your term. And so I did, and I'm really pleased that I did, because it wasn't that last year that we released the report on overweight and obesity, which I think has had already such an impact not only in this country but throughout the world. And it was in that year, of course, that we finished the National Strategy for Suicide Prevention. And I was just in Memphis last week participating in the first national conference on suicide prevention, but it was that report, which you see in the upper left-hand corner there, that sort of started that. So it was a tremendous opportunity to communicate directly with the American people and to establish a form of communication that will always be there, because when I left office, the National Library of Medicine decided to initiate a website on Surgeon General's reports, because I was the first Surgeon General to establish a Surgeon General's website. So now you can go to the National Library of Medicine and access any report ever produced by a Surgeon General in this country, including all of the ones that I produced. Well, the other thing, though, that was special in terms of my experience was that in addition to serving as Surgeon General, I served as Assistant Secretary for Health, and it was only the second time in the history of this country that had happened. And the first person, of course, is one of my heroes in medicine and public health, Julie Richmond, a pediatrician who, during the Carter administration, served as both Surgeon General and Assistant Secretary for Health. And Julie actually was the person who started the concept of healthy people in this country. And I know many people in this room have been involved with the Healthy People Project. So when I became Assistant Secretary for Health in 1998, one of my first responsibilities was to initiate Healthy People 2010. We were coming to the end of Healthy People 2000. So I had an opportunity to play a leading role in developing the goals for Healthy People 2010. And it was in that context that we set two goals. One goal was the increase to yields and quality of healthy life, and the other goal was to eliminate, not reduce, but to eliminate racial and ethnic health disparities. Now, the first goal is important, even though maybe it has not received as much attention, but I just want to say we set that goal because of what was happening to the American people, you know, and maybe people all over the world. We're living longer. Some people would say we're aging as a population. We gained 30 years of life expectancy in the last century, and that continues to increase. The fastest growing group of people in the country today, as you know, are people over 85 years of age. And that's really an amazing thing to watch, and in many ways a great thing. The problem, of course, is that half of the people in this country who are over 80 years of age are incapacitated mentally, physically, or both, and I'm sure all of us, one way or another, are dealing with that in our families. But I did hear the story the other day, which I have to tell you, that sort of puts a different perspective on that. It was about this great entertainer who had gone to this community, and the turnout was just outstanding. People came from everywhere to see him perform, and he got a tremendous reception, and people were just enthusiastic, standing ovations all over the place. He felt so good until he decided that before he left town he was going to visit a nursing home that was specifically devoted to persons with Alzheimer's and related diseases. So he went to this nursing home, and the press followed him, and which is what he intended for them to do. So he went into this nursing home, and he saw this lady in a wheelchair, and he went up to her and he said, ma'am, I mean, do you know who I am? And the lady looked at him and said, no, but if you go up to the front desk, they will tell you who you are. Well, but seriously, the issue of quality of life is a very important issue. It has major implications for our future. So I just want to say that even though it's not the goal that has received the most attention, it's a very important goal, and hopefully a lot of programs are taking place out there. But the goal of eliminating disparities in health is a very challenging goal. Many people have challenged the whole idea of setting such a goal, but throughout the history of Healthy People, we have set lofty goals, and we've continued to work on them until we've achieved them. And sometimes that's taken many years. Sometimes we just keep working. And I'm sure that's the way it's going to be with the commitment to eliminate racial and ethnic health disparities. If you read Healthy People 2010, and I won't ask you to raise your hands if you've read it, but there are a few people who have. But if you've seen the report, it's a 2-volume report, and it's the first time that Healthy People was put on CD-ROM. Donna Shalala was very excited about the fact that it was the first time that Healthy People was put on CD-ROM. But we struggle with a concept of determinants of health that I want to just take a minute and talk about. Because I think when people talk about disparities in health, we don't think about all of the determinants that we've got to deal with. So you hear about health care disparities, but you don't hear a lot of discussions about other areas of disparities that are going to have to be dealt with if we're going to be successful in eliminating disparities in health. So after a lot of debate, we came up with this framework. Now, some of you remember when Bill Foege and Mike McGinnis had that article, I believe it was in the New England Journal of Medicine in 1993, in which they looked at a lot of studies throughout history and asked the question, what are the major determinants of health? And they concluded that there were 4, that access to health care was important, that lifestyle was important, environment, biology and genetics were important in determining how healthy one was going to be, how long you were going to live, et cetera. And they tried to say, well, how important are these 4 components? And they concluded that lifestyle was probably responsible for 40 to 50% of the variation in determinants of health. You know, whether or not you smoke, your sexual behavior, or your diet, et cetera. They decided that environment was probably responsible for about 20% of the variation, biology and genetics another 15 to 20%, and access to health care, they decided, was responsible for only about 15% of the variation in determinants of health. I'm not saying that I agree with them, and that's why we did our determinants differently, because I believe that there's so much interaction among these determinants, and what this diagram attempts to do is to say that access to health care could have a major impact on your lifestyle. If you're fortunate enough to get a good physician who is as concerned about your lifestyle as other things, access to health care could have an impact on your environment. If your child sees a pediatrician who screens for lead and determines that child is being exposed to lead in his or her environment, I have known situations where entire housing projects have been changed because of a pediatrician who screened for lead levels in a population of children. So these are not hard and fast separations. There's a lot of interaction among these determinants of health. So we tried to draw that, and in the process, I'm sure, came up with a diagram that can be quite confusing. So I advise people to just start by putting yourself in the middle of that box. You are that individual, and you come with your own biology, whether that biology is related to gender, whether it's related to what we call race, and I could talk about that. A lot of things come from the biology. You know, your parents, grandparents, their longevity, all of those things are sort of related to your biology, your genetics. So you're that individual. But you also have environments. You have a physical environment in which you grow up. And in that environment, of course, it can be very motivating. I mean, you go to some places and you see these beautiful outdoors and walking and jogging trails and biking trails. The physical environment is important. It can stimulate active living, right? What we have not talked as much about, of course, and the physical environment can be negative. It is true that African American and Hispanic children are twice as likely to grow up in environments that are near hazardous waste sites. So when you talk about disparities in health, don't forget that that many of our children start off being exposed to toxins in their environments that are going to affect their cognitive development and other things. What we've not talked as much about is the social environment. And just recently, the World Health Organization decided to set up a commission on social determinants of health. And even though I had said that I was not going to join any more boards or commissions, I was so excited about the fact that WHO had decided to really attack the social determinants of health until I decided to serve on that commission. And we're looking at countries throughout the world, and countries like Chile, where they've made a major commitment to dealing with the social determinants of health, making sure that children of the poor have access to quality education from 3 months of age on up to the time they enter school, and have good nutrition. But social environment is important. Felton Earls at the Harvard School of Public Health recently published a study, which I don't know if you saw, but it was in the Journal of Science. And basically he studied children on the streets of Chicago for several years. And his study determined that children who witnessed violence, like a shooting or killing, when they were small, were twice as likely to be either perpetrators or victims of violence later than children who did not, and it was independent of socioeconomic status. Now, but even before we knew that children who are neglected and abused in their social environments somehow never completely recover from that in terms of their mental health and other things. So the social environment is important, and we should keep that in mind as we work to eliminate disparities in health. Access to quality health care is important, and it's received a lot of attention and still needs a lot of work. But up top of all of this are the policies and interventions. So I salute you for this policy conference and all the work that you're doing in policy, because I can tell you, you sort of get to a certain point in this struggle where you realize you can't go any further unless you can get something done about policy. And it's really frustrating. And I have lived that and continue to live it. You can be out there in the community working very hard, and all of a sudden the policy change hits you. Either it's a change in Medicaid, a change in Medicare. There are more people who are uninsured, and you keep wondering, when are we going to provide universal access to health care? But the policy is overriding in everything that we do. It sort of makes it very difficult. And so we've got to talk about policy. We've got to work together to try to move toward policies that are supportive of eliminating disparities in health. In Healthy People 2010, and this is, I think, the last thing I'll say about Healthy People 2010 directly, but we were concerned about the fact that there were so many objectives. We had only 2 goals, but 400 and something objectives. So for the first time, we put together what we call leading health indicators. And they broke down into lifestyle and health system. And I won't dwell on that except to say all of these indicators are really critical in our quest to eliminate disparities in health. Access to care, and obviously you have to add quality care to that based on all that we've learned. The mental health issue and the fact that we still don't have comprehensive comparative access to mental health services is a major issue. The environment, the immunizations, etc. Disparities are real, in case there's any doubt in your mind. And I'll just show 2 examples. This is from cardiovascular disease. And obviously, over the years, CDC does work looking at differences in mortality and things like that. This is taken from some of that work, and as you can see, there are major disparities in risk for dying from cardiovascular disease. African Americans and whites have the greatest risk in this country of cardiovascular disease, but there are major disparities between those 2 groups. African American men have about a 30 to 35% greater risk of dying of cardiovascular disease. And this, of course, is heart disease, but it goes over to stroke and other things. African-American women are about 40% more likely to die of heart disease than majority women. So one of the major examples of disparities is in the area of the leading cause of death in this country, cardiovascular disease. And if you look at cancer, which I won't look at with you, you see similar things. I did want to look at infant mortality, though, because these disparities start very early in terms of differences in survival in the first year of life. Whereas the majority of the population in this country have an infant mortality rate of about 6 per 1,000, and by the way, that's not among the best in the world, despite all of our resources. We don't have the best infant mortality rates, but African American babies are almost 2.5 times as likely to die in that first year of life as a majority baby, and American Indian babies are almost twice as likely to die. So there are major disparities in terms of infant mortality, and we still don't understand all of the reasons for those disparities. Obviously, we know that there are major differences in preconception experiences, the nutritional status of parents. We know that there are major differences in access to prenatal care, and all of those things. We know that if you look at low birth weight babies, major differences in low birth weight, and so from the beginning there are differences in risk for infant mortality, and then in the experience there are major differences. In the spring of this year, we published an article in Health Affairs, the Journal of Health Affairs, and some of you I know saw it because you've spoken to me about it. And it had a provocative title. It said, "What if we were equal?" And it was talking about if we had eliminated disparities in health in the last century. If by the year 2000 there were no disparities in health outcomes, how would the situation look? And looking at a lot of data, we decided, and you can look at this data for yourself because CDC publishes it, that in the year 2000, if we had the same mortality rate, and I'm using African Americans and whites because we have the most data on those two populations, there would have been almost 85,000 fewer deaths among African Americans in the year 2000 in this country if we had eliminated disparities. So we call those excess deaths, right? And it breaks down, among those 85,000 or so, about 24,000 fewer people would have died of heart disease, 7,000 fewer from HIV/AIDS, even almost 5,000 fewer babies, African-American babies, would have died in the year 2000 if we had the same infant mortality rate. Diabetes, a major growing problem in this country in all groups, was responsible for 22,000 of those disparities. And I wish I could tell you what's going to happen with diabetes, but I think this country and the world, not just this country, we are faced with epidemic. They say I overuse the word epidemic, but I know how to get people's attention. But so when I wrote the Surgeon General's report on overweight and obesity, you remember the title, right? It was about an epidemic of overweight and obesity, because that's how I saw it. I mean, I know the definition of epidemics, and certainly we are faced with an epidemic of diabetes in this country and the world, in great part because of the epidemic of overweight and obesity. So you get the picture. There would have been 2.5, and then when you get down to some of the policy issues, there would have been 2.5 million fewer blacks who were uninsured if we had the same rate of insurance of coverage, and that includes over 600,000 children who were not insured. So in a system where, regardless of race in this country, we have trouble with access, that's what it would have been like. Now, let me get to the end of the presentation and then try to fill in the middle. When you look at all of these things, we decided when we were developing our Center of Excellence on Health Disparities at the Morehouse School of Medicine, we looked at everything and we decided that if you're going to attack this problem, that you would have to attack it from at least these 5 perspectives. Access to care is critical, and it has to be dealt with if we're going to eliminate disparities in health. The quality of care, an area where we have so much research and where the Institute of Medicine has published a very comprehensive report. Lifestyle enhancement, improving environmental quality. And I have to tell you, I run into people all over the country who want to talk about disparities, but some of them just want to talk about health care. You start talking about lifestyle and they turn off. In part, people say, well, what are you saying? You know, lifestyle is a personal responsibility, right? Well, yes and no. Lifestyle, it requires personal initiative, but all of the children in this country are not equal in terms of their access to healthy lifestyle, whether it has to do with physical activity or nutrition. I mean, there are some cities in this country where it's not even safe for adults to be out on the street, let alone children, and there's certainly no parks nearby, no walking, biking trails. And the same thing is true for nutrition. You try to find a grocery store where there are fresh fruits and vegetables. So we've really tried to focus on things like the schools and saying that every school should be an environment that's conducive to children developing lifetime habits of physical activity and good nutrition. parents ought to be working with schools and vice versa. And so we started the program, if you haven't heard about it, called Action for Healthy Kids in 2002. And now we have 5,000 volunteers throughout the country working with schools, trying to get schools to return to physical education K through 12, trying to get schools to be models of good nutrition. And there's one here in Missouri, a program called Action for Healthy Kids, because we have them in all 50 states and the District of Columbia. Environmental quality and a balanced research agenda. We have to have research all the way from the basic laboratory research and clinical, all the way to community-based research, if we're going to eliminate disparities in health. Well, let me just take a minute and talk about access to health care, because I know that's something you're dealing with here in the state of Missouri, as we are all over the country. And when we looked at access to health care, we decided that there were at least 7 barriers to access. And we said we put them all in the category of uns. They're all uns. I mean, being uninsured is a major barrier to access to care in this country. And many studies have been done to show that. So I don't have to dwell on that. Being underinsured is a major barrier to access. Because I'm saying that because there's some people who argue that in this country, you know, everybody has access. The fact of the matter is there are major differences in access. Being underserved, and in Missouri, of course, a lot of diversity in terms of access to care based on where you live. Whether you live in rural Missouri or urban Missouri, different levels of access to care. Being underrepresented, and we continue to have in this country a health profession where there are major disparities in people who are entering medical school, nursing school, dental school, schools of public health, and we need a more representative core of health professionals and health providers generally. Health scientists, we need a more representative core. Being uninspired can be a major barrier to access to care. So in Atlanta, we are doing a lot of work with churches. We're working with people in the community whom we feel can do a much better job than we can of just motivating people. We have a major problem with black men, not just in Atlanta, but I think throughout the country, in terms of getting serious about health and health care and understanding that, you know, if you don't take care of yourself, you pay the price in terms of many early deaths from prostate cancer, cardiovascular disease. Black men have the lowest life expectancy of any group in this country for which we have good data. And I say that because we've just begun to get data from Native American and where you might see a lower life expectancy, but based on the population where we have good data, black men have a life expectancy of about 68 compared to an overall life expectancy in this country of about 78. And so we've been really focusing on what's it going to take to get men, and a lot of these are professional men, by the way, who don't take care of themselves, and I'm sure a lot of people in this audience who are like that. You don't have to be a black man to be guilty of not taking care of yourself, but we've targeted that population as being uninspired when it comes to that. And then a lot of it is untrusting. And nobody has to tell me the story of Tuskegee. I was born and reared in Alabama, and it was as director of the CDC that I commissioned the study of Tuskegee, headed by Vanessa Gamble. And if many of you remember, when that committee reported to me, I went straight to President Clinton, same day, and about Tuskegee and what it meant in this country. That was 1997. And in April of 1997, President Clinton officially apologized for Tuskegee, not just because our position was, and I want to say our, NIH was involved and others, we don't want just an apology. We want a strategy that says that this kind of thing, you know, where people are denied access to care because of their race, people are involved in research without being told that they're involved in research, people are not getting treatment when treatment is available. That's what Tuskegee was about. And different forms of Tuskegee, of course, have occurred in many places. But we tried to put in place some policies, NIH policies saying that, you know, if you're going to get funded for clinical trials, you have to show that the community is involved, CDC's community partnership programs. And still, it's a struggle in terms of people not trusting the healthcare system. And then, of course, some people are just not informed. And Richard Carmona, the President Surgeon General, I think has really brought this issue to the forefront. Richard has done a great job, Dr. Carmona, in this whole issue of health literacy. In fact, there's such a large number of, I think Richard said 90 million people in America who can't read well enough to understand basic health materials, and that includes a prescription in many cases. So the issue of health literacy, being uninformed, not understanding, is still a major issue. This is the, by now, well-known Institute of Medicine's summary report about disparities in healthcare quality. And this, hundreds of reports were looked at by the Institute of Medicine, and the outcome was that there are, in fact, major differences in quality of health care. And I won't try to get anybody to understand this diagram, because I'm still trying to fully understand it. But I think it's very clear from this diagram that you see the differences there in, I think this is, yeah. If you compare quality of care, all of the studies that were done, minorities and non-minorities, this is the difference in quality. And I won't go into all of the studies and what they showed. And they concluded that there were major two kinds of explanation. Some of them related to how the healthcare system is operated, and many of them related to discrimination, biases, stereotypes, uncertainty, things like that. So that was the Institute of Medicine study on the quality of health care. Well, we've tried to hone in on a few of these areas. Culture was discussed in that report, and they quoted from the report that I did as Surgeon General that dealt most intensely with culture was mental health, culture, race, and ethnicity. And in this report, they tried to summarize a lot of things, including a lot of points from this report. The culture of people determine how they manifest and describe their illness, how they go about coping with being sick, the type of stresses that people experience, and whether they're willing to seek treatment. All of these things are related to culture. And to the extent that we don't deal with them, then they interfere. And it would be great if it ended there with the patients, but it doesn't stop there. Healthcare professionals are influenced by our own culture. When I was in medical school, and after we used to talk about the culture of medicine, that there's a certain culture of medicine, then we discovered that there's a culture of surgery and a culture of pediatrics. I mean, you got these cultures going on here. But the fact of the matter is that healthcare professionals are influenced by their cultures, and sometimes it gets in the way of quality patient care. And in the studies at Institute of Medicine, it showed that it determines how patients were diagnosed, the kind of treatment that patients received, and how services are organized and financed. And people try to explain, why is it that African-American men are less likely to be referred for cardiac catheterization when they present with the exact same clinical picture, the exact same insurance coverage. So they control for socioeconomic status, and still there were disparities. We don't understand all of those things, and we don't understand the extent to which culture is a factor, but we can deal with that. So the AAMC is trying to get medical schools to put much more attention on culture. Nursing schools are probably leading the way in trying to deal with this issue of culture, and certainly schools of public health. But at Morehouse, at the Morehouse School of Medicine, we have this course called a crash course in cultural competency. And CRASH, of course, is an acronym which says that in taking care of patients, we need to consider culture, respect it, always assess it and affirm the importance of it, be sensitive not only to the patient's culture, but aware of our own culture. And then the tremendous importance of humility in dealing with the culture of other people, respect and humility. The environment, as I said before, is important, but let me get to the lifestyle. And just to say again, this is the Surgeon General's prescription, and everywhere I go I pass out Surgeon General's prescriptions. Soon after I became Surgeon General, and you get to be known a little bit, and people come up to you and ask for your autograph. And I was not the most friendly person when it came to doing autographs. So my staff and I sat down and we decided to make some good use of my autograph. So came up with these prescriptions. And I mean, there's not a single medication on here. It still took me 4 months to get it through the FDA. But finally, And if you see that little notation up in the left-hand corner, not to be used to obtain medication, that finally did it. But this speaks of the importance of regular physical activity and 5 days a week, at least 30 minutes a day, the importance of fruits and vegetables in the diet, importance of avoiding toxins like tobacco, and being responsible in our sexual behavior. I was the guest speaker 2 weeks ago at the Atlanta Public Schools. Every year they have this big thing where they have a speaker and they bring together high school students from throughout the city, and it was my turn. So my staff and I decided that we were going to give each one of these students a prescription. So we came there with 1,000. And I was talking to the assistant superintendent before my speech, and I said, we want to pass these prescriptions out. We'll probably do it afterwards because we don't want to interfere. So she stood there and read the prescription, and she said, yes, yes. And then she got to responsible sexual behavior, and she said, oh, no, Dr. Satcher, we can't talk about that. I said, why can't we talk about that? She just said, we just don't talk about sex. So it's so political. Well, I think that's ridiculous, and I told her. And I also told her that I was going to talk about it in my speech, so were they going to cancel the speech? So she said, I tell you what, Dr. Satcher, why don't we just pretend that I didn't see this? I said, okay. So we pretended she didn't see it, so I talked about it in my speech, and we passed it out after the speech, and the students lined up for prescriptions and asked all kinds of questions about it. But you see what we're dealing with when it comes to lifestyle. When politics gets mixed up with lifestyle, we have some major problems. I went through that at the CDC. As many of you know, I went through that in my confirmation for Surgeon General. The way we have politicized public health and things like HIV prevention. People are dying because of our politicization of public health issues. And it affects people adversely and differently in different racial and ethnic groups. So it stands in the way. I'm not going to talk about the mortality survey except to say that it showed that mortality ratios were still decreasing for African American males, but for African American females, I should say increasing for males, but they were beginning to decrease. And when we asked ourselves why African American females were doing better, we found that there were a few things that were involved. African American women have closed the income gap from 66% to about 90% over the last 40 years. But for men, it has not closed very much. It went from about 68% to 78%. But also, I think our health system, because of the coverage of pregnancy, prenatal care, 62% of African American births are covered by Medicaid. Very important program for African Americans. And as you can see, that program is more important for African Americans than it is for whites, because there are more African Americans who are poor and who need Medicaid. So when there are policies affecting Medicaid, it doesn't affect all groups the same. So disparities get worse, right? Just keep that in mind. Coverage for men, different situation. And many black men die before they're eligible for Medicare, because if you're eligible at 65 and the average of the life expectancy is 68, that means almost half of black men are dead. And so those are the kinds of things, but violence, gun-related deaths. So these are some of the things that we have to attack in addition to quality health care. But we concluded that you need universal health insurance. We're trying to get the men in Atlanta to have a primary medical home. We need better representation in the health profession, bias-free interventions, and nonviolent and exercise-friendly neighborhood. Story about the South Carolina, the Texas farmer who was visiting South Carolina, a story that I've told a few times, but it's important here. And of course, this Texas farmer was from a farm that was 5,000 acres, and he was visiting South Carolina and decided he wanted to visit some South Carolina farms. So he was traveling along, and he decided to stop at this particular farm, and he sat on the porch with the South Carolina farmer, and they talked about farming. And he said to the South Carolina farmer, "How big is your farm?" And the South Carolina farmer hadn't thought about that a lot, but he said, "Well, maybe 60 or 70 acres." And the Texas farmer thought, "My goodness, his farm, my farm is 5,000 acres. If I tried to explain that to this guy, he wouldn't even understand." So he said, "Let me tell you a story." He said, "There's some mornings when I get up, and just as the sun is coming up, I will get in my truck and drive across my farm, And do you realize that when the sun is going down, I still have not gotten to the end of my farm? South Carolina farmer scratched his head and he said, you know, I used to have a truck like that. Let me tell you, when you're representing the United States at the World Health Organization, and you try to explain that we spend more than any country in the world for health care, that we spend more per capita, larger percentage of our gross national product than almost any other country, and then you try to explain that there are almost 50 million people who are uninsured, there's something wrong with that truck. There's something wrong with this truck, and it's time for us to fix it. And if we don't fix it, we will never eliminate disparities in health. If we're going to do it, we have to care enough. As a nation, we have to care enough. As health professionals, public health leaders, we've got to care enough. That's why they call this the health care area, because we're supposed to care first and foremost. But we've also got to know enough. We've got to continue to research. Got to be willing to do enough at all levels of government and community. And we must be persistent. So at Morehouse, we've developed what we call the three-dimensional approach to eliminating disparities in health. And we try to represent it by this cube. But basically what we're saying is that it's important at any given time to know where you are. What are the disparities in cancer, heart disease, excess deaths? How are we impacting those by our programs? At the same time, you've always got to be asking and answering questions, and that's the balanced research agenda across the top there, from laboratory research all the way to community health interventions, and we've tried to develop research in all of those areas. And then, of course, you've got to be willing to implement what we know, whether that knowledge is about environment or lifestyle or health care, or whether it's about how different people are affected by different drugs because of their biological makeup. Whatever the difference is, we've got to be willing to attack them. I hope you won't despair. It's a tough challenge, but John Gardner was right. Life is indeed filled with golden opportunities, carefully disguised as irresolvable problems. Thank you.
Wow, wasn't that terrific? We have a few minutes for questions, so if you would please stand up and state who you are or where you're from and ask questions. All right, well, let me give you an opportunity, and then I'm going to ask the first one. All right, anyone else? All right, Dr. Satcher, I guess my question is around what can we do at the national level specifically for health disparities in terms of federal programs? What should we be changing along those lines?
Well, I think when you think about the role of the federal government in this country, it's always been my impression that the federal government was special. You know that old story when people talk about the constraints of government, they say that the two biggest lies of history are, one, the check is in the mail, and two, I'm from the government and we're here to help. But despite what they say, when you think about it, government is the only institution that's responsible to all of the people and supposedly representative of all of the people. Government has a tremendous responsibility. So to the extent that there are imbalances in access to care, government has a responsibility to target those. Government has a responsibility to make sure that if there are imbalances, disparities in healthcare access and quality, that there are special governmental initiatives to try to bridge those gaps. So I think the role of government is paramount. I think it's tremendous in this regard, and I think we've got to get to the point where our policies match that responsibility. You remember when we came out with the mental health report, one of the major things that we targeted in that report was what? Parity of access to mental health services. So we recommended comprehensive parity of access to mental health services because people with mental health problems, and that had nothing to do with race, by the way. That had to do with the fact that there are almost 50 million people in this country who suffer from a mental disorder each year, and half of them were not getting care. And so when we looked at some of the reasons, it was that we don't have the same coverage for mental health problems as we do for other problems. And so out of that report came a major recommendation for comprehensive parity of access and an attempt to model that through the federal programs. So the government has a responsibility to fund research that will develop models for eliminating disparities in health, answering some of the major questions for which we don't have answers. That research funding is a major part of the responsibility of government, but also policies. As McKinley in his model said, there are 3 levels of intervention. One is downstream, dealing with individuals. Another is midstream, dealing with community. And then there's upstream. And it's that upstream, those policies upstream, that can make it very difficult for you downstream. So government has a major responsibility. Yes, sir.
In looking at the access to healthcare issue, if you examine it, African Americans do not have, aren't as low in terms of uninsured levels as Hispanic Americans, but they are more likely to be enrolled in Medicaid. But when you look at the health disparities, typically what I see is African Americans showing even greater health disparity than Hispanics, even though the levels of uninsured are not the same, which makes me then look at the Medicaid system, because if a large number of people that are enrolled in that Medicaid system, and we still see these huge disparity issues, it makes me wonder, is there something systemic in that system, and are we examining it and trying to figure out what we have to do for as long as we're stuck with this arrangement for healthcare access? How do we fix it?
Did everybody hear the question? It had to do with the fact that even though African Americans don't necessarily have the worst uninsured rates in the country, more likely to be in Medicaid than Hispanics, yet we have health measures that tend to be worse in areas like infant mortality, for example. Well, I think the Hispanic population, among other things, are made up of many people who are here without being necessarily citizens who qualify for certain services, and one of the things that we're struggling with. And also, it is very true that people coming from Mexico and other areas tend to come with better health. The longer they stay here, the worse it gets. You know, in other words, very clearly, being poor is more dangerous in America than it is in Cuba when it comes to infant mortality. Somehow Cuba has an infant mortality rate that's better than the United States, despite the fact that we spend much more money. So the longer you stay in this country, if you're poor, the more you're endangered in terms of, so it brings out a lot of things about environmental poverty. You're absolutely right. When people come from other countries, the longer they stay here, the worse their health indices, if they're poor, if they stay poor. And so it is one of those difficult dilemmas. Our healthcare system does not treat poverty kindly. And so it's dangerous to be poor in America. I guess that's one of the messages here. It's dangerous to be poor in America. Yes?
I'm Dr. Senior Care Dentistry. What can we do in the health field to convince the government or politicians that certain areas of medicine is not optional, such as dental, eye care, podiatry, and they cut their programs and look at these things as optional services when they all tie into the human body?
Good question. The question was, and you're a dentist? Yeah, the question was, what can we do to convince the government that certain areas of health care are important and not optional, like oral health, eye care, and other things. Well, you know, I did the first ever Surgeon General's report on oral health, and I must say the response to that report was one of the best responses in terms of things changing. The Robert Johnson Foundation and several others funded 19 programs in the country to try to improve access for children to oral health services, but also many dentists throughout the country. I was just in the county around Michigan State, Ingham County, Michigan. And they had a program there where the dentists were volunteering just 5% of their time. And by doing that, they were now providing access to dental health services to over half of the uninsured children. We tried to make the point in that report that you're making, I think, that oral health is a critical part to overall health and well-being. That if you are not healthy in terms of your oral health, then you're not healthy. And we know more and more, of course, of the connection between things like periodontal disease and heart disease. We don't always understand those connections, but we know that there's an association between periodontal disease and birth outcomes and diabetes and heart disease. So this connection that we tried to make in that report, more and more research is showing that that connection exists, but clearly we have to be as concerned about oral health. And we call it oral health. We didn't call it dental health because we wanted to make the point that anybody engaged in health care should be concerned about the health of the mouth and the related structures because it was very important. So it's a great point. Last question?
I'm Nancy Gaffney. I'm a family nurse practitioner in rural Missouri. One of the problems that we have, of course, is just the number of providers. In Missouri and many other states, you have to be in a collaborative practice with physician practice. With the retirement of a physician I've been working with for 8 years, my practice was lost also to our community. 30 years of research has shown that advanced practice nurses do a really good job in primary care. Do you have any thoughts on that? I mean, on a national basis, this is occurring in every area of poor access, where we have willing providers like myself. Do you see any national policy that could improve that balance of care and access?
The question was about family nurse practitioners and their role in improving access to care, especially in areas, rural areas and others. And I think it's very important. There are parts of the country where there have been major efforts to prevent nurse practitioners from actually practicing, especially independently. Let me just say, it's one of those situations where I think the biggest problem we face is a lack of adequate support for primary care. And therefore, what we have sometimes are primary care providers fighting each other. Primary care physicians are not adequately reimbursed for their services and are very concerned about anything that may be threatening to that. And I think there's a major need in this country for us to shift more and more of our resources into primary care and preventive medicine. And then we won't have to pay so much to treat diseases and their complications. So I think that's the biggest issue. But I also think that states have to be able to come up with models that allow them to get health care to all of their people. And those models have to fit the needs of that state. And I was involved in training family nurse practitioners because when we started our family practice residency program in Los Angeles, we also had a family nurse practitioner program. And many of the physicians and nurse practitioners went into practice together. And so I think you have to fit the system to the needs of that community. Okay. Let me close with a favorite quote because I don't want to leave you with any sense of hopelessness, even though this problem is overwhelming. It was Benjamin Elijah Mays who said something that has stuck with me throughout my life. He was president of Morehouse when I was a student there. He said that it must be borne in mind that the great tragedy of life is not in failing to reach all your goals. It's in having no goals for which you're reaching. It's not a calamity if you die with dreams unfulfilled, but it is a calamity not to dream. It's not a disaster if somehow you fail to achieve your highest ideas, but it's a disaster if you have no high ideas for which you're striving. Not a disgrace to fail to reach the stars. It's a disgrace to have no stars for which you're reaching. In the final analysis, he said, and I say to you today, it's not failure but low aim that's sin. So let's keep aiming high to solve this problem. Thank you.
Thank you, Dr. Satcher. Dr. Satcher has a very busy schedule today, so we're going to let him get on with that. And we now have a 15-minute break for networking, but please keep it to 15 minutes. Well, actually, we're going to get 12 and a half minutes now. So at 9:45, we'll start our next panel.